Good evening, everyone. My name is Ara Sherwani, and I'm a research scholar in the Department of Psychology at the Leader Muslim University. My work focuses on understanding the chronic illness experiences of young adults living with IBD. I also live with Crohn's disease myself, and I'm currently working with IBD India on their mental health initiatives. I'm grateful to Nikhil for the opportunity to host this session, and I'm very pleased to be in conversation with and learn from our guest speaker, Dr. Arshia Bhardwaj. Dr. Bhardwaj is an attending consultant in the Department of Gastroenterology at Dayanand Medical College and Hospital, Ludhiana. She recently completed her DM, and as part of her thesis, she engaged with over 200 women living with IBD to better understand their lived experiences and unmet needs. Her work highlights an important gap in our context and contributes to the kind of evidence needed to bring about meaningful change in healthcare system and policy. At IBD India, we are especially excited about this work as research focusing on lived experiences, particularly in resource-constrained settings, has been long overdue. Today's session will begin with a short presentation by Dr. Bhardwaj, followed by a question and answer discussion. We encourage everyone to share their questions, thoughts, and reflections in the chat. We'll take them up after the presentation. With that, over to you, Dr. Bhardwaj.
Thank you, Zara. Thank you, Nikhil, for the opportunity. I'm very grateful for this platform. Actually, this is not just a simple piece of work that's done on paper and published, but what I'm going to tell you today and present you today comes directly from patients themselves. Those 202 women who I spoke to, who trusted me with this. I think I'm giving them a platform so that their voices can reach all of us. And I hope they give us some lessons and we also find solutions together, because I know you all are suffering and you've gone through a lot. All of you are, battlers on the front field. So I hope that this research could make a difference. I'll keep working. There are doctors like me who are working, and we will keep working for the benefit of all of you patients. So I think we'll begin our study today. I'll just share my screen. Yeah, is it good now?
Yes.
Is this visible to everybody?
It's good.
Okay, we'll begin now. Good to go? Hello?
Yes.
Okay, perfect. So good evening, everybody. So I did my thesis and my research on impact of inflammatory bowel disease on women's health in India. And it was published in Intestinal Research, which is the official journal of Asian Organization of Crohn's Colitis, in November 2025. And my mentors were Dr. Ajit Sood and Dr. Arshdeep Singh. And under their guidance, I did this study. So IBD is basically a very dynamic disease. It's affected by environment, genetics, and immunology. But the gender affects incidence, symptoms, and severity. And all these factors are secondary to differences in genetics, hormones, and psychosocial factors. Gender impacts every aspect of IBD. In the Western countries, you see that the prevalence of Crohn's is more in females than males. And in India, we see that males have slightly more prevalence of inflammatory bowel disease in them. But the issues with females are slightly different because they could go through puberty, pregnancy, menopause. All of that also differently affects inflammatory bowel disease and impacts the disease activity also and affects them as well. Other psychosocial factors like mental health, stigma, they also affect the disease burden. Women not only face difficulties while going through the disease itself, but they also face barriers to specialized care, due to social stigma, socio-cultural, and systemic differences. So in this study, we aim to assess the impact of IBD on women's health across multiple domains and identify unmet needs in low and middle income countries like ours in India. So health is not just physical health, it is a combination of physical, mental, financial, environmental, and social health. So we and sexual health, and we evaluated all these aspects in all these 202 women. So this was a cross-sectional study, and it was a questionnaire-based study and a semi-quantitative questionnaire-based study. We did it at Dayanand Medical College and Hospital, Ludhiana, which is a tertiary care center in North India. And we collected the data from June 2023 to December 2024. All adult females with confirmed diagnosis of ulcerative colitis or Crohn's disease were included in the study. And the data collection followed a semi-structured face-to-face interview conducted by me as a single trained investigator to ensure consistency. And we had the ethical approval, of course, and the consent of the patients. So while assessing the females, we focused on different aspects of health, not just the disease characteristics. We focused on the demographics, of course, the disease characteristics, the extent, severity, and activity of the disease. We also did some lab investigations to evaluate anemia in our patients. We focused on reproductive health issues during pregnancy, breastfeeding, their doubts during pregnancy, breastfeeding, their HPV vaccination, their knowledge about reproductive counseling, have they ever received reproductive counseling. We focused on their sexual health as well, where we asked them about the quality of their sexual experience living with the disease. We also asked them about difficulties they faced during their sexual experiences with their partners during the disease. We also ask them about their body image issues. So a lot of our patients, and I'm sure a lot of you feel some body dysmorphia while going through this. So we documented on a visual analog scale, and we asked each and every female about how they felt about their body before the beginning of the disease and how they feel now after they've suffered for quite some time from the disease. We also evaluated their social health. So this was a very important aspect where we saw and we asked them about their relationship with their family, their in-laws, their partners, even their friends. And we also applied a score that's a sick IBD score, which evaluates the, so basically it's a social score done in chronic conditions in IBD. So it evaluates the impact of IBD on education. It evaluates the impact of IBD on job, personal relationship, their ability to balance work and the disease. Also, if they faced any rejections during job because of their disease. So all these aspects were covered in this score. We also evaluated the environmental health. The environmental health part basically included the changes in their diet, how they're adjusting to it, how they're accommodating to it. And then if they were traveling for such a long distance to their doctors, did they have accessibility to clean toilets during the travel? Did they have accessibility to clean toilets at their home? Then comes a very, very important part of health, that is the mental health. So we applied some scales like perceived stress scale and HAD score, and we evaluated different aspects of mental health, including stress, anxiety, and depression. The results I'll be discussing soon. And financial health. In this, we asked the total income of the family, and then we evaluated how much they spent in a month on the disease, either the travel, the medications, and we evaluated that, and we found that the results we'll be discussing soon. So we evaluated 202 females with IBD. 155 of them had ulcerative colitis, and 47 of them had Crohn's disease. The median age of the cohort is 41. In the mental health, we saw that about 99% females said that they had high perceived stress, moderate to high perceived stress. 74% of them felt depressed, and 70% of them had symptoms of anxiety in some form or the other. When we came to the menstrual health, the median age of menarche is basically the beginning of menstruation, was 12 years, which is usual in the normal range. They belong to the normal range. And the median age of menopause was 44. In the Indian cohort, we've noticed that the median age of menopause was slightly earlier than the Western cohort. It could be because of nutrition and other hormonal factors. 50% of them had irregular cycles, menstrual cycles, and about 28% of them complained that IBD worsens during menstruation. So, for females, it's slightly different because the effect of estrogen and progesterone hampers the disease activity and also vice versa. So, menstrual health and IBD mutually affect each other. So, we asked about their sexual practices. So, 88% of them had never been advised on contraception. And I hope all of you know that HPV causes cervical cancer. The incidence of cervical dysplasia in inflammatory bowel disease is slightly higher than the general population, more so in ulcerative colitis. However, we have vaccines available for HPV. I think it's in the national program as well now. But the vaccination rate was only 4%. And 97% of patients had never received advice on cervical cancer screening. It was shocking to see that this number is so high. When we came to pregnancy, so in pregnancy, we started with asking them about, you know, how many live births they've had, how many stillbirths they had, the complications of pregnancy, and what were they most apprehensive about pregnancy. So 60% did say that they were very apprehensive about conception. The reasons will be discussed in the next slide. 3% had stillbirths and 21% patients had spontaneous abortion. So the stillbirth rate overall in India is slightly higher than the Western countries. But in India also we saw that in IBD patients, the rate of stillbirth is higher than the general population. And requirement was for assisted reproductive technology was only in 1% of patients. So if we come to the left top box, you can see that 21% of patients had spontaneous abortion and 3% had stillbirth. Although this percentage may not seem very high to you, but this is a very significant number. And when we ask them about the reasons of apprehension about conception, almost every reason was an apprehension for conception, but heritability of IBD worried most of the patients. Then congenital anomalies in the child, complications during pregnancy, adverse effect of medications, financial concerns, 13% struggled financially, and also lack of family support and difficulty in raising the child alone. So these were their apprehensive thoughts for conception. So when we come to the sexual health, so there's a scoring system that we used, a scale that we used, that was the ASEX score. So in this score, we asked the patient about their sexual experiences during the act, about how if they could reach their orgasms and if they were satisfied enough, if they had the sexual desire still left in them. So 82% of them confirmed sexual dysfunction on this score. Pelvic pain, abdominal pain, and perianal pain being the most troubling symptoms during the sexual act. 70% of them interrupted sexual act due to pain, and similarly, 70% of them avoided sexual act due to pain. So the number is quite high. 80% of females had anemia, they had hemoglobin of less than 12, and more than 50% had iron deficiency anemia. Reasons for anemia in IBD are varied: iron deficiency, B12 deficiency, nutritional. A lot of factors contribute to anemia. So when we come to social health, so we did a sick IBD score. So the sick IBD score was in the moderate range. It was zero point 0.6. 21% of our IBD patients faced rejection in marriage. 42% of the patients were unaccepted by their own family. It was shocking to see and it was shocking to hear for us as doctors that their own families did not accept them because of stigma of the disease and the pressure of being a female unable to perform their caregiver duties. So the in-laws, the unacceptability rate, perceived unacceptability rate was quite high. It was 76%, very high. Uh, so we also did this in their social circle and workplace. The number was quite shocking as well. 60%, 50 to 60% experienced, perceived that they were not being accepted in their society, which is quite sad in today's time. So the sick IBD score, if you see the bottom chart, this chart, I'm not sure if you can see my cursor. 94 patients experienced relationship breakup because of IBD. They also experienced relationship problems while suffering from IBD. They experienced help with carrying out physical activities while living with IBD. They've lost their job. They've suffered, uh, changing their jobs. It has affected their earning capacity. It has uh, endangered their job, and also their education was interrupted. So when we come to the environmental health, so 70% of our patients had difficulties with diet because when we are prescribing diet and IBD, sometimes we tell patients during their active disease, limit milk or limit wheat. So since in North, predominant diet is wheat based. So it is very difficult for patients to adjust, which we completely understand. But sometimes, that takes a toll on their mental health as well. And the access to IBD specialists in hometown was only for 25% of patients. 80% of patients, sorry, I don't know what happened. Sorry. Where is this? Uh, can you see my screen?
Yes, it's
Yeah,
visible.
I don't know what happened. Okay, perfect. So, 80% of our patients traveled more than 4 hours to receive basic IBD care. And similarly, 80% of these patients also had difficulties in accessing these medications because some of them are advanced therapies. You don't get them at local chemist shops. And especially in villages or small towns, it's difficult to access these medications. So during their travel, as I told you before, we asked about accessibility to clean toilets, which is a basic right for everybody, not just patients per se, but for everybody. 70% of our patients had difficulty in accessing toilet. So this was mainly about the environmental health. I'd also like to talk about the challenges faced, while making changes to the diet. Most of them felt that there were too many restrictions by the treating doctor, and also they had a difficulty because they had to cook for themselves separately. And also, family members play a big role when we, manage such a complicated chronic disease. So there's lack of support from family members. There are too many dietary advices from family members. All of these are challenges for our patients, to achieve that holistic healthcare that we want for them. So to conclude, this is one of the first study in India that has been done, which includes almost every aspect of health. And it highlights the multifaceted impact of IBD on women in lower middle income countries. We also highlight the need of not just women centric, but also gender sensitive and holistic care. We advocate for integrated models of IBD care, including reproductive health, psychosocial support, preconceptional counseling, And health healthcare is not a necessity, it is a fundamental right. So we advocate for equitable healthcare for everybody. And we know that healing in IBD is not just medicine, it is a step forward towards a more balanced, inclusive world. Thank you.
Uh, Thank you so much, Dr. Bhardwaj, for that insightful and engaging session. We'll now move on to the questions. We have a set of questions from IBD India, and then we'll move to specific questions that we received from the patients.
Okay.
The first question is, what inspired you to take up this work?
Uh, this is a very tough question and very close to my heart. So I just completed my DM, as you know. So the first month of my DM, when I joined my residency, there was a patient on bed number 3 who I still remember, who had a very complicated, she was suffering from Crohn's, and she had a very complicated perianal fistula. She underwent surgery, although she was doing well. But while speaking with her, I realized there's something still missing that's not making her happy despite battling big difficulties from her disease. I saw that there was no family support from her own family also, and from her in-laws also, and there was a slight differential treatment. So that's just one of the example. I had another young girl who was 20 years old. She was suffering from Crohn's disease. She had a bad perianal fistula. She was very troubled. She got better. The family's main concern was, will she get married? Will she be okay? Will she be able to have children? Will she be able to conceive? And for the patient herself to battle with the disease, even when she was in remission, the stress, the trauma, you know, her entire mental health was disturbed. It was very difficult for her to open up to anybody because I think women are believed to perform certain duties in the family, and certain roles which are specific to women. They're expected to perform their caregiver roles, the listening ear roles. So sometimes I think because of our society, the social cultural differences, this slight ignorance in the family themselves, where they forget to ask, are you okay? It's a different thing to just take medications and feel better, and it's a different feeling when somebody comes to you and just asks that, are you all right, are you doing well? So that was one case. There was another patient who had had big difficulty in coping up with the thought of, she did not have a very severe disease, but the entire thought of just having a big diagnosis was so difficult for her. She told me that I've just got married. What will I do? My life is over. My in-laws will not accept me. So many patients, females, I've spoken to before I began this study, they used to tell me, please don't tell our in-laws. Please don't tell them about our disease. They will not stay with us. So I thought that, this is beyond medication. Before we make a change and decide about which way to go, we need to know what the issues are in the society, right? And this, I had the zeal. So Dr. Ajit Sood and Dr. Arshdeep Singh, I think they were the ones who conceptualized it and who pushed me forward to do it. I had my doubts because this was a big questionnaire. And for anybody to entrust a doctor and reveal deep personal details, which are also obviously beyond the questionnaire, is difficult. So I'm so glad that I got this opportunity. It has broadened my vision for my patients, and it has given me so much strength to keep working in this path. We're also doing more studies. We've done previously, I think a year before publishing this study, we've already worked on mental health. We've seen prevalence of depression and anxiety and stress So in that study, we also found that females were more likely to have these symptoms. So that's how it began. I have so many stories. I think there's nothing more inspiring than seeing patients like you who come to us, who are battling their everyday lives and still making it. So there's nothing more inspiring than that.
Thank
Dr.
you so
Arshia,
much.
just stop sharing your screen.
Oh,
Yeah, so
I'm
it will
so
be better.
sorry. I'm so technically challenged. I'm
It's
sorry.
fine.
Perfectly all right.
Okay, perfect.
Thank you so much for that answer. Uh, the second question is, why do you think it has taken so long for this kind of work to happen in India?
You know what? When it comes to chronic illnesses like IBD, there's a trajectory in every disease that is followed. It's not like people were not working on it, but initial thought was to control the symptoms, control the severity, and, gradually proceed forwards. So once, there have been so much research on controlling the symptoms, severity, and I think that's substantial work. India has done substantial work in it. So everything has to follow a certain kind of trajectory and process. So now we're at that process where we're starting to focus on holistic care. So I think it's just the natural way it's supposed to be.
Right, right. Moving on to the next question. Most autoimmune illnesses affect women disproportionately. Can we then not frame them as women's health issues during health and policy advocacy?
Um, this is a good question. So, you know, I agree that, women are affected by autoimmune diseases disproportionately. But then just creating women centric guidelines would just narrow the scope of what we want to achieve. Health equity for everybody. I think our vision should be to create guidelines through a gender sensitive lens instead of a gender specific lens, right?
Right. Um, the next question is, research increasingly highlights gender differences in how patients are heard and treated in healthcare settings, with women patients feeling that they are sometimes not taken as seriously or having to advocate more strongly for themselves to be heard. From your perspective, both as a clinician and a woman, have you observed this? And how can we address it, both in clinical practice and in patient awareness, especially in the context of IBD care?
So I think this is true. I won't deny it. I think women do face some difficulties slightly more, but I won't completely say that it's entirely true. I think a patient suffering from IBD sometimes as a whole does feel that they're being heard less. So as clinician, I think it is important for us to create a multidisciplinary approach. You know, we need to work like a team. It is not just a doctor who's required to treat an IBD patient. There are dietitians that are required, there are IBD counselors, there are therapists who are required. So treating IBD as it is a multifaceted disease, we also need a multidisciplinary approach. And as clinicians ourselves, I think patience is key, empathy is key, and kindness is key. So as long as we remember these three things, it's easy to hear our patients. And for
Right.
patients themselves, where they feel that they're unable to speak out, I think that begins at home. Every patient has a right to be heard. So if you feel that, one place is not being suited to your requirements, I'd suggest always consider a second opinion. Voice your opinions. Don't be fearful. The doctors, we're not here to judge you. We're here for you at all times. Sometimes, because we're overburdened, we might seem that we're in haste. But at the end, all doctors go through a long, lengthy process of getting here, studying for 15, 18 years. So majority of us, I'd say I can't vouch for all, but majority of us, we're here for all of our patients at all times. ठीक है?
That's comforting to hear. The Uh, this question is related to the question that you just answered. So I was reading some of your research papers, and in one of your research papers, you highlight how overburdened healthcare systems often lead to rushed consultations and limited time for patient education, and propose IBD counselors as a way to bridge this gap.
Yes.
Given that developing and scaling such roles will take time in resource-constrained settings like India, what can be done right now to improve doctor-patient communication within existing constraints?
So I agree IBD counselors play a very big role. So we have IBD counselors in our department who,
Mhm.
bridge that gap between doctors and patients, and they're more accessible at any point of time. We have that WhatsApp support group. We have given them separate numbers of our IBD counselors. But then again, since we cannot do this immediately, I think patient support group is also a brilliant idea. Like Nikhil, you've created this patient support group. So somebody who's suffering from the same disease can share similar sort of pain. So patient support group is one. And also we have nurses in our system who we can, train, because if you're asking me about the immediate step, what we can do, we can train our nurses, the young budding resident doctors, we can train them, the interns, we can train them, whoever come to the OPD and posted in the OPD, we can train them to address these questions. But ideally, in an ideal system, we need something, a program like that of IBD counselor, who bridges the gap between dietitians, nurses, psychotherapists, and doctors and patients, right? And I think that's about it. Yeah.
Right. Nikhil, would you like to ask?
Yeah. So, ma'am, I think on that, on the IBD counselor point, like as we saw in the results also, uh, like there is an aspect of social and financial uh, thing also. Like they are not accepted in jobs. Our job is affected. Lots of other things are affected. So even when we talk about holistic care, so again, like we need a larger ecosystem than we think. Like is basically a lot of it is medical. Like the doctor can again counsel them about, let's say, reproductive things, or we can have a dietitian, we can have a
Mhm.
psychologist, but then we need someone like a social worker also,
Yeah.
or like someone like a patient counselor.
Mm.
But even in terms of a patient counselor, I think the patient counselor needs to be much more capable than just knowing the medical aspects and the
Yeah.
like. I feel like they need it needs to be like a training program where we address all kinds of things. Like
Yeah.
previously we had done this training for like other patients and all,
Yeah.
but I felt like it does not uh, give people the required, let's say, psychological skills, like even mental health care.
Mhm.
It's not very accessible for everyone,
Right.
and all systems are overburdened.
Mm.
And like you said, like patient support group is one option. Then again, people like Zahra, we have so many mental health professionals in our community who are both patients. So, and in the West, we have like, GI psychologists.
Mhm.
So I think we definitely have components to build like a rich ecosystem.
Yeah, we do.
But we are trying to, like, I think a little bit of, advocacy in the policy side is also required, or a little bit of empowerment from the policy side is also required, because we cannot control the society so much, right? Like, I think menstruation and all these things are still a stigma, and I don't know for how many years they'll continue to be. So I don't know if only awareness will be enough to tackle all these issues. And I feel like somewhere, and again, this is new for us also, and new for doctors also, because we ourselves, like patient advocacy in IBT has just started, and we just started doing this work since 5 years and all. So I feel like we need some, like we need to work together, like with doctors and all, and to advocate, for like some policy change also, to give protections to people with, again, not just IBD, other illnesses like IBD also. Because I think all of us, like as patients, whenever we interact with other patient groups also, it's almost the same problems. And initially we were waiting on evidence. So I'm very thankful that you took up this work. So now we have some evidence to talk to people. But somewhere I also feel like that it's such a slow process that sometimes it's very disheartening. But anyways, like that's okay. Like that's why I was so happy to see that you took up this work, and I know it must have been very difficult and very challenging, and I'm really, really thankful. Like I cannot express how thankful I am. Like in the last 15 years of my disease journey, like I think intestinal ultrasound and your study, these are the only two things that have given me hope that things are changing for patients. Like those are the only things that not in I'm not saying that things have not changed, but those are the only things that make us feel like our experience is changing as a patient. Otherwise drugs keep changing, but our experience does not. So
Mhm.
I think these are the two things that give us some hope that our experience of living with this disease will change in the coming future. So apart from this comment, the only question that I would like to ask is, like we talk a lot about holistic care and patient person-centered care and all of that, but right now what happens is, and again, this might be a flaw of the system itself. There are many other factors, but the entire burden of following up with many doctors and different departments, especially as your IBD progresses and you have many complications and all, falls entirely on the patient. So what can be done to decrease the like burden of receiving holistic care from the patient side?
I think holistic care, I mean, holistic care is a challenge, but the burden shouldn't. And I'm very saddened that you every patient feels that it's totally upon them. But I think it's our responsibility as doctors that this disease can be controlled only by teamwork, and teamwork doesn't just limit to doctors and patients. It also includes families, besides dietitians, nurses, and to increase the accessibility to holistic care, we need to start raising issues first. Okay, more doctors like me, and all of us are doing work in this field, need to come up with questions before actually bringing the change, right? And from the patient's part, I think hesitancy is what I feel. Patients feel a little hesitant to express what they actually need. So I think that needs to be eliminated. It's difficult, I know, because it works both ways. It's our responsibility as doctors to make you feel comfortable so that you comfortable enough to speak with us. And similarly, it's the patient's job also, that they've traveled so much, they're suffering from a disease, they need to entrust in their doctor for whatever they need to get better. And to make the process easier, it needs to work as a team. The entire burden shouldn't be on the doctor, it shouldn't be on the patient. So there should be a structured plan. When a patient comes to you in the OPD, ideally, this is an ideal situation which we'd like. When the patient comes to an OPD, the doctor speaks to you, he tells you about your disease, prognosticates you, tells you about the medications, asks you about your worries, and then identifies. So if you're somebody who's planning to conceive, he tells you that this is the area you need to go get preconception counseling. It is very important, right? Then comes the patient's part. To follow that advice will always be your part. And then if you're stressed, sometimes patients come to us and they tell us that we're stressed and we're depressed and we have these issues. When we talk about therapy, do you know how low the acceptance rate of therapy is, how stigmatized therapy is? And it's not by the patients, but the familial pressure of listening to that word therapist is so difficult, right? So it can't just be a one way path, it's two ways. Listening for us, similarly listening for you. What advices, right time, right advices need to be given by us. So I think it's achievable. See, 5 years back, nobody would have thought that you would have created this group. 5 years back, I wouldn't have thought I would be able to do this study. So every change is a positive change. And change begins with an individual. So when we talk about, policy making, first we need to ask ourselves that have we accepted the disease? Have we stopped stigmatizing our own disease? Have we finally let it empower ourselves? Right? So I think that's how we need to begin. Every step forward is progress.
That is so true. Like, I think we have been running a mental health helpline since now 3 years now, and out of three people, only one person actually picks up the, like, when the counselor calls them, they say that yes, I registered and I want therapy. Otherwise, two people, either they deny that हमने तो register ही नहीं किया था, or they will say like कि I don't want it. So yeah, except like even when mental health care is available, I think yeah, a lot of things are stigmatized. And yeah, I think when we began this organization also, like one of the first things we discussed was like our relationship with ourselves. And there also the same points were discussed, that first as individuals we need to accept like this disease, this condition. And I think as patients also and as community also, I think we need to grow a little bit before we can take those bolder steps towards like systems change and everything. But yeah, certainly,
I think
I think
sorry, I'm interrupting. Your biggest strength is this patient support group. This this platform that IBD patients have. I wish everybody could access this platform and they know about this, and everybody is not hesitant to join this platform, because nobody understands your journey more than somebody who's going with you in that journey. So this patient platform is very, very important. It's important to raise questions so that they can be answered in future, right?
yeah, 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 that is true.
And also, I want to
And
mention, you were telling me, Nikhil, that you were inspired by my work. Honestly, I cannot tell you how thankful I have been to those women. They have changed my perspective about being a doctor, about life itself, and the amount. I'm a female myself, so I can relate with a lot of things, although I'm at a very, minuscule scale, because I'm not battling with the disease. But the amount of courage they've given me to speak up, and so many lessons I've learned from patients like you, to have a voice, to stand up for myself. So I think I'm more grateful for all of you that I've been able to join this work than you could ever be for me.
that is exactly like, and I think like that's why it's reciprocal, ma'am. I think when we also started, like it was very difficult for us to find our voice, and even it took a lot of, like, even now I think there are instances where we find it very difficult to speak up for ourselves. So to find people like yourself who talk to these people and with like honesty, like, you could have just sent someone to like, okay, go talk to these patients, get them this form filled and all. That could have, you could have done, but you actually like sat down, listened to all these people. So that is actually like hopeful for us, that okay, like some efforts we are making, some efforts doctors are making, and hopefully in few years time things will actually look good for us also and for the newer generation of patients also. But yeah,
Definitely.
so I think we'll move on to some patient submitted questions. So yeah, Zara, you can.
All right. Before I do that, the whole session reminded me of my own journey. 10 years back, I got diagnosed, and at that time, we did not have, I mean, I was completely in the dark about what IBD is. And I think the process of acceptance for me began with having a good conversation with the doctor, because uh, doctors have a very important place in the lives of a person with a chronic illness. And no matter how many patient support groups we make, or talk amongst ourselves, we do not feel fully accepted until our doctor says that, yeah, I understand what you're going through. So that clinical interaction is so significant. And, from my own experience and now that I'm researching on this topic, I feel that having just one doctor be empathetic and to listen to you with, their heart, it can change the entire journey of a patient. And so that is why I am equally grateful as Nikhil is that we have more doctors like you to interact with us and make us feel more heard, because feeling heard is like the beginning of the whole acceptance journey, and dealing with it comes after.
You guys are making me very emotional right now.
I'll move on to the questions from the patients. Um, yeah. So the first question is, I'll just state the question as it was given. I was diagnosed with Crohn's in 2020. 3 to 4 months before the diagnosis, suddenly my period flow reduced and it is still very low. In 2020, I did AMH test where I was found to be at a low fertility level. For the last 5 years, I was not in complete remission and period flow is same, only for 2 days. I get periods on time, though. I have asked many doctors, but no one answered my question. I want to know, why is my period flow low?
Uh, so thank you for the question. Uh, Disease activity does affect the menstruation cycle and the flow. There have been studies which mention that menstrual changes usually precede, in some cases, they precede the diagnosis of IBD. But since your periods are on time and 2 days, so there's always a range of menstruation which is considered to be normal. So the range is usually 2 to 5 days. And since your period flow and your periods are on time, they're coming regularly, I hope. So I don't think there should be a fertility issue. But controlling your disease is the most important part. Fertility in IBD patients, as such, the fertility rate is equal to the normal population, the general population. It's not affected by the disease until and unless the disease is active, or there's some kind of perianal disease or some kind of surgery that patient has undergone. Fertility is also affected by psychosocial and mental health. So otherwise, the fertility rate remains the same. But whenever if you have too many issues, I think you should consult a gynecologist. But always keep your gastroenterologist in loop. Your IBDologist, the treating doctor, in loop, because sometimes there are medications which might interfere with your disease. So both the doctors, the gastroenterologist and the gynecologist, can discuss it as a team. What could be better for you, right?
All right. The second question is, I'm below 30 years of age and unmarried. Will I face problems in the future after marriage if I plan to conceive? Am I actually low in fertility or is it a temporary problem?
Actually, again, as I've already told you, there's no difference in fertility rate. I mean, in the general population and IBD patients, the most important deciding factor is disease activity. So before always get counseled before conceiving. Tell your doctor, inform your doctor that this is how I plan to go about conception. So he will make sure that you're on the right drugs and your disease is controlled and everything will be great. So whenever we talk about studies and we tell you about risk factors, it's not like these are absolute contraindications to conception. But this is what we suggest in the best interest of our patients and what evidence suggests. The disease activity is the most important thing, and also smoking status. Today, I have seen a lot of young females, who started smoking. So I'd say smoking is a big no-no.
All right. Moving on to the third question. In the corporate sector, we often feel pressure from our seniors related to our targets. I feel pressured and tensed. How should I deal with these situations? How should I reduce that nervousness?
So, we did this sick IBD score I talked about. So workplace difficulties are real issues, losing jobs, financially, being stigmatized. So I'd suggest you begin with yourself. It begins with accepting your disease first and being vocal about it at your workplace. Only when you confidently accept that, okay, this is my body, I am going through this, you'd be able to tell others that this is your body and this is what you're suffering from, and these are your requirements. So instead of overburdening yourself, structured planning is required. Prioritize your goals, right? And sorry, did something happen? Okay, we've got a question.
Yeah, we'll reach out to them.
And while you're working, make sure that you take short goals. Short breaks. You don't need to be continuously sitting to work. And communication is key. Very important to communicate to your bosses. And if you think the workplace is too toxic, there's always an option to find something else which is better for you. Easier said than done, but health is the most important, priority that should be there for you. Be it your mental health, be it your physical health, controlling your disease, feeling emotionally confident is very important. And also set your goals. Instead of, overbearing yourself with 10 goals a day, stick to short schedules, right? I hope this helps.
Yeah, it's definitely helpful. I think in workplaces there should be more awareness about people with chronic illnesses
Definitely.
and how. Yeah.
The only way of awareness, how does awareness come? We keep talking about, awareness, this, awareness, that. It comes from us. Somebody has to take that initiative. Who's better than taking an initiative than somebody who's already suffering from the disease? We have big platforms like social media. Talk about it. Everybody talks about so many things. Somebody is going to listen to you, I'm sure. Social media is a big platform. I think we're very utilizing it not to our fullest capacity, right?
Next question, ma'am. I have erosions in my cervix and facing leukorrhea and heavy bleeding. I'm not able to receive proper treatment for it. My gynecologist has suggestions, but I'm unable to make a decision. What should I do?
See, these are serious complaints. If you don't feel satisfied by a single gynecologist, take a second opinion. You know about cervical dysplasia and cervical cancer being slightly higher than in IBD than in general population. I think we should take this seriously. Whatever is stopping you you should focus on that. If you think the advice is not right and if you're not satisfied with the advice, so maybe consult another doctor. Keep your gastroenterologist in loop simultaneously, right? Take gynecologist's advice. Search for a doctor or change your doctor if you're not satisfied, but follow through. Somebody's asked about heritability.
Yeah, ma'am. So coming to the questions in the chat, I think we'll come to that. Like there was a previous question also. I have colitis for 13 years, have anxiety issues too. What are the other impact on mental health in IBD?
So what we've studied so far, I just talk about India for now. So we've studied that, stress, anxiety, depressive symptoms are quite predominant in patients with IBD. Even in our study, we also found that even if patients are in remission, they still face those issues, right? And these issues can manifest in a variety of symptoms. Some people could experience depression in a certain way where they isolate themselves, and some patients may, experience or express depression in an entirely different way. So the most important part is that if you have these issues, please go get help. Tell your doctor, seek therapy, don't stigmatize it. Every kind of doctor, therapist is there to help you. So just don't stigmatize it, because all of these mental health issues also affect the disease itself. and also decrease your own quality of life, right?
Yeah.
Right.
I think the next question is, ma'am, many women with IBD are facing chronic fatigue and morning sickness, irrespective of remission or flare, or even without any period issues. How do we address this issue?
So fatigue is quite predominant in IBD. It is known there have been many studies which, suggest that fatigue is a big issue with patients. I think there are a lot of nutritional deficiencies in women when it comes to IBD and overall also. So, again, consult your doctor, make sure you're supplemented well, get your right blood tests done so that these nutritional deficiencies can be identified. And I'd say that, get into some sort of light, low physical activity like yoga or meditation. Because, when you exercise, not heavy exercises, something like yoga, meditation, it naturally releases endorphins in your body. And endorphins positively affect your mood, right? And fatigue is also again related to your mental health issues. If you're too tired and drained by your disease, and if you're anxious and if you're stressed because of your disease, all of this can lead to the feeling of fatigue.
Yeah. And then your next question is, can you tell more on IBD being hereditary in nature?
So the inheritance in IBD is only 3% if one parent is affected. But it usually increases to 30% if, both the parents are affected. So if you're just one person, there's no heritability. You don't have to worry about heritability. It's just a 3% risk. So you know what? There've been studies where they found that voluntary childlessness is more common in patients with IBD. So just out of the fear of conception, just out of the fear of side effect of medications, heritability, despite comparable fertility rates in normal population IBD patients don't conceive. About 30% patients refrain from conceiving because of voluntary childlessness. So I think discussing with your doctor is the most important thing. Having the correct and the right kind of knowledge is important. Stigmatizing your own disease will hinder your process of battling with the disease. So heritability, only 30% of both parents have IBD. Otherwise, only 3%. You can breastfeed while you're suffering from disease. The only thing is, before planning conception, your disease should be in control. It should be in remission, right?
And then Pratiksha is asking, can you give us more information on the HPV vaccine? Does its efficacy reduce with age and start of sexual activity?
So HPV vaccine is recommended in the reproductive age group, and it's quite efficacious. I'm sorry I can't give you the numbers because I'm not very I've not recently read about it, but you have two types of vaccines. You get either 3 doses or 2 doses, and now previously the age group was only 45 years of age. Now they've also increased the age limit, and they've also started including men in the HPV vaccine program. So it's quite, I think all females should get HPV vaccination done, despite believing otherwise.
So basically at any age they can get, right? Like at any age, whatever you are.
Yeah, reproductive age, they must. I think the age group age has been increased to, I think 60 or 70. Need to check. But reproductive age group, yes, must.
Okay. Next question is, what can male partners do better to support women with IBD through different stages like prayers, treatments, and mental health challenges? And how can male caregivers be meaningfully integrated into holistic management of women with IBD to improve both clinical and psychological outcomes?
Hashtag, I think this is the most important question. I've been waiting for this question. throughout. I think partners of any IBD patient, they should be able to support them. They should be able to support them in their mental health journey. They should be able to support them in their can the best they can start with is just hearing them out. Just hear them out. When they come to you with their difficulties, sometimes don't even give them a solution, just listen to them. Take them, make sure that they get their appointments right, they go to the hospital, and they take their medications on time, and just be there for them emotionally. I think that's the most important. Once, as Zara mentioned it before, when you hear a patient, जब आप किसी की सिर्फ बात सुन लेते हो ना, तो आधी तकलीफ उनकी वहीं खत्म हो जाती है. तो पहले सिर्फ सुनो, उसके बाद उनसे ही पूछो कि what do they require. If they're asking you to be a shoulder to cry on, just be that. So just be there for them in whatever form they want you to be. Also, there's a caregiver fatigue. So sometimes the caregivers of IBD, the partners of IBD, they also get tired. So make sure you communicate well through your relationship. I'm sure a therapist can tell you better, but communicate well and appreciate each other. That's what both of you can do to support each other, because fatigue is both sides. Also, how can male caregivers be meaningfully integrated into the multidisciplinary management of women with IBD to improve both clinical and psychological outcomes? So I think male caregivers, if you're clinically certified, then sure you can help. But even if you're not, you start with your family. When we talk about, how to bring a change begins within the family. When you are supporting your partner, make sure you extend that awareness in your family itself. Because in the disease process, I think it's the entire family that's required to support the patient. So create more awareness in your own family. And to be integrated into the multidisciplinary management, join patient support groups like this, spread awareness through such kind of patient support groups. But clinically, I'm sure you'd need a degree to help, right? I think this is what you want to ask.
I think, ma'am, also like you said initially, that when we talked about access to holistic care, I think caregivers can play a big role in bridging that fatigue of accessing that holistic care. That I am myself tired. I don't want to go to 100 appointments. If there is my caregiver and my partner is helping me do that, I think that itself is a very big support.
I completely agree. I mean, as a partner, only if you hear your patient out, I think that solves 90% of the problems. Rest of the 10%, take them to the hospital. Be there with them when they're struggling through the entire process of waiting, going to different doctors. Make sure, that you're at least clear about the schedule they need to follow. Because sometimes patients who are in active disease, it is very difficult for them to self-care. So make sure you're well versed with their disease and the medications they're taking and what their requirements are.
Yeah, and this question is a little bit out of scope.
Yeah, I think talking about FMT currently is out of scope.
Okay.
Yep.
So I think, ma'am, this is a good point to, I think, end the webinar, and also we are out of time. But I would like your views on one last question. So ever since we started this work, and I think when we started, like we as patients didn't know what we could do, right? And I think mental health was one of those things that we felt like, is very important, but nobody really talks about it. And so we started doing some work on mental health and all. But what we see is that, and this is true more for like, people who have individual practices of things, is that like we have a resource for free mental health care. We are doing a lot of work to kind of sensitize other therapists also as what life with chronic illness is like. So we are trying to build awareness of chronic illness amongst other therapists also, among the wider psychology community. But what we see is that when patients go to doctors, even though they know that this is a part of evidence and all, they fail to at least tell the patient that go and access care. And I'm not saying everybody is doing this, but there is a part of the like community of the healthcare community who kind of they are also, I think, not willing to accept that the extent of impact I feel is that what it can have on a patient's healthcare outcomes. That is one thing which I feel. And uh, like what I feel it comes down to is like not, like I feel like we want to work with the doctor community. We want to work with doctors and societies, and again contribute to like some meaningful large scale change, right? But and doctors like Ajit sir and Vineet sir, and we have received great support from a lot of like some of the best doctors, but we have received equal like demotivation or discouragement from a lot of other doctors as well. And now, why I'm asking you this question is because again, people like you are like now just entering into the field, like, and then for the next 10-20 years, we will be interacting with you. So as someone like you, or like, or your peers from their point of view, what do you think can we as patient societies or patient advocates can do better to develop better relationships with you, to work better with you, so that we can like compound the impact of everyone's work, whether that is your work or our work? So how do you think like doctors and patients can work better together?
I think, collaborative work is very important. For that, platforms like this talk we've conducted, which is I'm so happy, between patients and a doctor. I think we need to do something like this and more of this. We could also do some research which could be led by patients and doctors together, right? Because we know a doctor's perspective, but from a patient perspective, we could do patient centric research led by patients themselves in collaboration with doctors as well. And also more social media appearance. I'd still say that social media makes a big impact. So collaborating either on social media platforms or physical platforms. And our generation, as we're growing older, our generation is slightly more aware about mental health issues. So we keep advocating in our community about these issues, not just mental health issues, sexual health. It's so difficult for anybody to talk about sexual health. So I think for us, it is a learning point that we need to be more vocal about it and not stigmatize it ourselves. And for patients also to do the same. So when you come to the OPD, just go ahead and ask the doctor that, this is what is happening to me. This is what I'm facing. I'm facing difficulties in marriage. Okay, you told me that 50% of doctors listen and 50% don't. Hold on to those 50% who listen. And we will carry you forward. Work with us, we will carry you forward. And we won't let you fall. Right?
Yeah, thank you, ma'am. That's very encouraging. Zara, any closing comments?
Yeah, uh, just that now these conversations have become much more uh, out there in the open. But I remember, again, I'm referring to my own experience, but 10 years back, I didn't know that, talking about mental health is something you can do in a clinic. It was the doctor that I was seeing, and I came upon that doctor after a lot of bad experiences with doctors. He asked me, how is your mental health? And I was a bit taken aback that, does this fall in the purview uh, of what is allowed? Because there's this whole authority thing
Mm.
between a doctor and a patient that no matter how frank your doctor is with you, you kind of prescribe to that role.
Mm.
And it lifted such a weight off my shoulder because I felt like, oh, I can talk about this and then we can communicate. We can talk about what medications, what are the other alternatives, what medication is working for me, what is not working for me. So those interactions, I think a lot can happen in those interactions.
Hmm.
And if we keep having these interactions outside and inside the
Yeah,
clinic, we will definitely make change. And thank you, Nikhil, for organizing all of this. And thank you so much, Dr. Arshia. It has been a great privilege talking to you, and I hope we can remain connected.
for
Uh,
sure. Definitely.
yes. Uh,
Thank you so much,
Nikhil,
ma'am, for giving us your time. Yeah.
Thank you, Nikhil. Thank you to all the patients who joined today. Thank you, Zara. And thank you for all your questions. I'm so happy to be here. I hope we keep doing this. I hope I can help you in so many ways. Whatever you need, I just want to let you know in this closing point that, majority of our doctors are built on empathy. Those certain bad experience shouldn't pull you away from doctors, because we spend our lives working for the betterment of patients. And not all of us, but I can vouch that majority of us want what's best for our patients. And that's what we're built on.
Yeah.
So I hope,
Thank you so much.
please go open up to your doctors. Don't hesitate. I'd be happy to help anybody who needs help. And Nikhil, I hope that we can collaborate more. And Zara, I'd be happy to see your work. And
I would
I'm
be
so
glad.
inspired by all of you. This is a great platform, and I wish you all the best, all of you.
Thank you so
Thank
much,
you so
ma'am.
much.
Okay,
So we'll just end the webinar then at this point.
perfect.
Thanks.
Have a great
Thank you
evening. Thank you so
everyone
much.
who attended, and
Bye bye.
yeah, back to I think OPD for you, Dr.
No, I have to go back to endoscopy.
All right.
It's
Okay,
my
take
happy
care
place.
then.
ठीक है चलो
We
Take care.
can't always see the same,
We
but
can't say that.
hope you have fun.
okay bye bye.
Bye,
All right,
ma'am.
take
Bye.
care.
And thank you everyone for attending. So we'll just close out, and whoever could not attend, we'll put up the recording webinar. Thank you, Zara, for moderating and giving us your
Thank you,
time as well.
Nikhil. Thank you.
Okay, take care. Bye, everyone.
Take care. Bye bye.